Hello, welcome to another session of Digital Slide Review. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a service of Path Presenter and the Digital Pathology Academy. Our case discussion today comes from the realm of GYN pathology. The patient is a 59-year-old woman who's had some vaginal itching and notes a little bit of an asymmetric bulge at the vaginal introitus. I think this clinical presentation raises an interesting differential because on examination, the clinician felt that this looked like it might well be a cystic lesion. It was slightly fluctuant, not fixed or hard. So what are the cystic lesions that we might encounter in the vulva? Well, certainly the most common lesion is the Bartholin Duct Cyst or the Bartholin gland cyst. But we also can encounter epidermal inclusion cysts, either around hair follicles or occasionally as a post-surgical inclusion related to, say, an episiotomy or something like that. Mucinous cysts of the vestibule also occur. Those are usually midline and located between the urethra and the vagina. Hidradenoma papilliferum most commonly occurs in the milk line, a little bit lateral, and often anterior to the vagina. And then there are the more mesothelial-derived cysts, the so-called canal of Nuck cyst, and Skene's gland cysts occasionally also enter into this differential. So that's an interesting differential. Those can be distinguished on the basis of location, on the basis of epithelium type, and a variety of other features. But the histology will be slightly different, of course, in each of these. Well, so this lesion in our patient was excised. It was slightly lateral to the vaginal introitus. Not really sure if it was posterior or otherwise. And as you can see, we've got multiple fragments of tissue without much of a cyst lining, maybe a little bit up here. We suggest some sort of a more cystic, complicated structure. But here we see that we've got squamous epithelium here without keratinization and without much evidence of other features. No mucus glands in this tissue. Here's another area where we see the epithelium is still squamous, stratified, squamous mucosa, maybe tending a little bit towards transitional, but not really truly transitional. And here we see more squamous mucosa, fibromuscular stroma, no keratinization, no viral cytopathic effect, although here you might say there's a little pseudo coilocytotic change, or maybe even some of you might wonder about a true dysplasia in a location like that, and a little bit of inflammation as we move more towards the surface of the vagina. So with a tissue like this, there's not a whole lot we can say other than to be descriptive in terms of the tissue. So we would say squamous epithelium lines tissue with fibromuscular stroma, no unequivocal evidence of neoplasia, no specific evidence of dysplasia or viral cytopathic effect, although we might wonder about it there locally in that one section. So taking that as our lead, let's go on and talk about where the anatomy of these lesions is derived. So the epidermal inclusion cysts primarily are derived from the hair shaft. And so they're going to be on the labia majora and further out, maybe anterior, maybe a little bit posterior, but they're not going to be part of the vulvar squamous mucosal type surfaces, not part of the vagina. Skene's glands are primarily located around the external urethral area, and so these will be anterior for the most part in the vulva. The canal of Nuck, as you may recall, runs along with the round ligament. Again, would be more lateral and associated with the erectile structures and is associated with the labia majora. Hidradenomas, we've mentioned, is a milk line-derived lesion that's going to be composed of apocrine glands, tissue, and so that can occur on the minora or the majora, and so that also can be found here. Vestibular cysts are usually central here and would not be lateral, and that's where to be thinking about those. As we can see here, the Bartholin glands are located just exterior to the labia minora and sort of posterolateral from the vaginal orifice or hymen. Well, here's another example pulled from our files to show you a little bit more of how this lesion might appear. This, I'm not sure, was particularly a duct cyst per se, although it does look a little bit dilated. And here again, you see stratified, probably more squamous, maybe slightly transitional type epithelium. But I think you can see it's becoming a little bit more squamoid here along the surface here. And very bland appearance, no complicated architecture, no atypia, no viral cytopathic changes here at higher magnification. So features consistent with Bartholin's gland cyst. We've reviewed where those tend to be located. And so this lesion, as well as the previous one, were signed out as compatible with, based on location that was provided, a Bartholin duct cyst. Now, the Bartholin duct cyst is typically the dilated space with a squamous lining. There may on occasion be some seromucinous glands, either in the wall of the cyst or occasionally along the surface epithelium. These can become clinically important, particularly if they become inflamed. And that is usually due to some sort of obstruction in the duct egress and leads to a sort of polymicrobial abscess cavity. Treatment for these lesions is going to include some sort of drainage, so either a dilatation type of procedure to drain the cyst, or if necessary, either marsupialization or potentially excision of the lesion with attendance to how the gland is going to be drained following excision of the cyst. Those should manage the problem acceptably, and usually, of course, you'll begin with the least aggressive or invasive procedure to see if you can obtain that without a more aggressive excisional surgery. So there is our final sign-out diagnosis on this case today, a Bartholin duct cyst presenting at the vaginal introitus with completely benign squamous epithelial lining. Now, consistently, these can be, or conceivably, these can be associated with condylomatous changes, particularly that could lead to partial obstruction of the duct, and so that should be considered as you evaluate these lesions. Well, we hope you enjoyed that case, and if you did, please hit the subscribe button. Please like it, and that'll allow others to view this video. We apologize to any of you who tuned in the first time without sound, and hope that our instructions have been fruitful as you have listened a second time, or listened the first time and watched the second time. So until next time, thanks so much for joining me.